And let's go.
Okay, I think it's time to get started. All right, so hello everyone and welcome to the Hope Beyond the Headlines Alzheimer's Disease webinar brought to you by the Alzheimer's Association Greater Pennsylvania Chapter and the All of Us Pennsylvania Research Program. My name is Brittany Ardino. I am the Marketing and Communications Manager and a Research Champion for the Alzheimer's Association Greater Pennsylvania Chapter. It's great to be here with you all today. We have a lot to get to, and we have an expert panel here today who will be taking your questions. We will get to the questions from the registration form first, but if you have any others that pop up throughout the webinar, please feel free to add those to the Q&A button and we will try to get to those later. Also, just a heads up, this webinar is being recorded and will be available on our YouTube and social media channels after. That will be for the All of Us and the Alls GPA social channels. So first, to kick us off, I would like to introduce our Executive Director for the Alzheimer's Association Greater Pennsylvania Chapter, Clay Jacobs. He has served in the role since 2018 and has been working on behalf of Pennsylvanians impacted by dementia since 2008. Under Clay's leadership, the chapter has consistently been a top performer in all areas of the strategic plan and has developed a wide variety of initiatives and partnerships. This work includes significant expansions in state policy, advocacy, and health systems, the development of online and telephone support services, and community engagement initiatives. Clay has been a participant on many nationwide association strategic planning groups, is a member of the Pennsylvania Department of Aging's Cultural Diversity Advisory Council, and has previously served as an inaugural member of the Pennsylvania Alzheimer's State Plan Task Force. So please welcome Clay Jacobs.
Thank you, Brittany. And that's a lot, considering I think the best thing I can do this morning is to get out of the way so we can get to our expert panel. But it is a privilege to be here today to kick off this important discussion, and grateful to each of you for taking your time to be here in the audience, as well as all of us for serving as a host for this, because ultimately our mission at the Alzheimer's Association is to lead the way to end Alzheimer's and all other dementia by accelerating global research, driving risk reduction and early detection, and maximizing quality care and support. That accelerating global research portion is probably most applicable today as we convene, collaborate, and fund to try and do just that. The Alzheimer's Association globally is the leader in Alzheimer's and dementia science, and the most impactful nonprofit funder worldwide. Currently, we have over 320 million invested in over 1,000 projects in 54 countries. But locally, that same commitment is true. There are total awards in Pennsylvania of 115, totaling 21 million. And even right here in the Pittsburgh area, we have 10 active awards funding at just under $2 million. Ultimately, whether it's global or local, at any given moment, research, learning, and discovery is happening. We also convene scientists and researchers through roundtables, work groups, professional societies, and more, including the world's largest dementia-focused research conference, AAIC, which, after being held in Amsterdam this past summer, I'm incredibly proud to share with this group will be back in the US and be held in Philadelphia in July of 2024. And through all this, we also want the public and all communities to better understand and participate actively in research. All of this and more than we have time for today has led to some of the excitement and advancements you'll hear about today. Some of you also may be aware about things like 2 new FDA-approved treatments that treat one of the underlying hallmarks of the disease. We also know additional clinical trials are underway and offer the hope of additional treatments, along with work in biomarkers, tau, risk reduction, and so much more. And so as we enter this new era in research and treatment, it's particularly important for you to be here with us today and to share what you've learned. But I cannot say enough for the folks you'll hear from, because in so many ways, Pennsylvania is leading the way, with folks like you'll hear from our panel today, but even others. Dr. Oscar Lopez and Dr. Jennifer Lingler at the University of Pittsburgh are serving on the main study group of something called ALZNet, a project to connect clinical data from Alzheimer's patients to medical professionals and researchers so that we have more information sharing and education, that we're driving innovation in the ways we care. And so For so long, the families and those we've advocated for and provided care and support have looked towards hope and research. And we are entering that time where we can be as hopeful as ever. And so thank you for joining us today in this exciting time. And ultimately, I'd ask us to remember, when research is proven, it becomes treatment. And when treatment is delivered, it becomes care. So thank you for caring about this topic, giving of your time, and thank you to all of those who you'll hear from shortly about the work they do each day. Thanks, Brittany.
Thank you very much, Clay. We also have 3 doctors with us today from UPMC and the University of Pittsburgh. So first we have Dr. Tariq Pascal, who is a neurologist and an associate professor of neurology and psychiatry at the University of Pittsburgh School of Medicine. Dr. Pascal's clinical and research interests include cognitive disorders of multiple etiologies, including Alzheimer's disease and other dementias. He has also received multiple awards and honors, including the Dr. Albert and Pauline Spatz Family Distinction Award and the Barrett Family Foundation Distinction Award, both from the Alzheimer's Society of Canada, as well as the IPN Montreal Neurological Institute Star Award and the Dale Schenck Alzheimer's Association Roundtable Award. And if we can also please welcome Dr. Thomas Kari, who is an assistant professor of psychiatry at the University of Pittsburgh Alzheimer's Disease Research Center. He is on the Committee for Aid in Education and Neurochemistry and the International Society for Neurochemistry. Dr. Kari's research interests include pathological changes in the Alzheimer's brain, blood biomarkers for Alzheimer's disease, and diagnosis. He has received the Best Alzheimer Publication Award from the Swedish Alzheimer's Foundation and the Astrup Prize from the Nordic Federation for Clinical Chemistry. And both doctors also attended our Alzheimer's Association International Conference in Amsterdam this year as well. And finally, we have Dr. Melinda Massert, who is a board-certified family medicine physician at UPMC and associate professor at the University of Pittsburgh. She currently serves as the founder and director of the UPMC Primary Care Precision Medicine Center, chair of family medicine at UPMC Magee Women's Hospital, and is a co-director for the Hub Core, integrating special populations and community partners core at the Clinical and Translational Science Institute. Her research interests are in developing education in genetics and precision medicine for primary care providers and trainees, and to be a research catalyst facilitating the inclusion of underrepresented populations in biomedical research. Dr. Massert is also a co-principal investigator for the All of Us Pennsylvania Research Program. So a big welcome to our panel. So let's get started. Dr. Massert, why don't we start today's panel with you? In case anyone is unfamiliar with the All of Us Research Program, can you share a little bit more about the program with us and what it all entails?
Yeah, absolutely. And thanks so much for having us today. I'm super honored to be on this panel with my colleagues who are truly experts in dementia and Alzheimer's research. And I just want to share a few words about the All of Us research program. And I think Clay, really alluded to the connected mission here around there being so much we still don't understand in medicine and in science. And the more we understand, the better we can actually care for each other in healthcare. And that is truly the mission of All of Us. This is a national research study, the largest study ever created in our country to recruit over 1 million individuals across the country to be represented in a database so that research investigators from all the way from academic and pharmaceutical companies to the level of high school research teams could access this data and study this data and really truly hope to better inform our care going forward and to answer some of these questions that have truly remained unanswered for so long. It is a precision medicine study. And so to do precision medicine, we are capturing genetic information as well as health record information, and then lots about our environmental exposures, because so much of how and where we live, even the nutrition that we eat and the activity that we are able to get into our routine every single day has an impact on our overall health and development of disease. So for me personally, I am very invested in advancing precision medicine, in really truly trying to understand conditions such as Alzheimer's disease, which actually runs very strongly in my family, and to understand both the inherited risk as well as the environmental contributions that ultimately lead to this condition. And then how can we better actually tailor treatment for this condition to either prevent symptoms or minimize symptoms as much as possible. So that's just a little bit about the All of Us research study. And if you're interested in participating and have not joined yet, I think my colleague Katie can probably put that information in the chat. But I'm going to pass it on back to you, Brittany. Thank you.
Okay, thank you very much. Great information. So speaking of genes and genetics, we were asked if there are any new statistics on the prevalence of getting Alzheimer's disease in patients that had familial genetic markers. Whoever would like to answer, feel free.
You want to go, Tarek?
I can answer.
Yeah.
I think this question came from since you are talking here about headlines, about the new publication that showed that patients that have a familial gene have resist more to the pathology. We have a paper that have a publication, I think 2-3 months ago, in a court in Colombia, where they showed that the patient have the familial mutation, and this patient did not develop the Alzheimer's disease. But talk about prevalence for who I think first we need to explain the difference between the genetic Alzheimer's disease and the sporadic Alzheimer's disease. And this is very important because we receive a lot in our clinics, people that did the genotyping things such as 23andMe and saw that have a higher risk of develop Alzheimer's disease due to a gene, and saw movies such as Still Alice, and they are very concerned that will define that they have a diagnosis of Alzheimer's disease. Thus, you can differentiate. You have, let's see, to simplify, you have 2 types of Alzheimer's disease. The sporadic Alzheimer's disease that you're going to call the common Alzheimer's disease. That's the Alzheimer's disease that will be talked mostly here today. And the genetic Alzheimer's disease. That is a rare form of Alzheimer's disease, less than 5% of the cases. This genetic Alzheimer's disease, we should start to think, doesn't mean that you're going to have, but to start to think when the symptoms start before 65, 60 years old, can be as early as 30. And when you have this patient have a first degree relative or a parent, a father or a mother that have Alzheimer's disease or have a declining memory, and this starts before the 65 years old. This is a rare form of Alzheimer's disease. The question is about this form of Alzheimer's disease because this form of Alzheimer's disease have 3 genes that you know. The name of 3 genes are preselin-1, preselin-2, and APP. These 3 genes are genes that determine that the patient is going to have Alzheimer's disease. Then what he asked about the prevalence, there is something called penetrance. Penetrance are autosomical dominant genes that theoretically the patient should have the phenotype of the disease, but in a small percentage of the case, the patient does not develop that. Then if you take in general lines, the penetrance of these genes of Alzheimer's disease is very high. I would say more than 95%, have some genes that are 100%, some genes that are a little bit less. Then you can say that most of the patients that have these familial genes we're going to have Alzheimer's disease. More recently was discovered in this paper that was in the news, more recently was discovered that besides the penetrance, have some people that develop in the phenotype of Alzheimer's disease, develop the pathology, amyloid and tau, but they have some resilience and resist to the development of the cognitive symptoms. Then what I will say to answer the person in a simple way, there is no change in the prevalence, and you take together the penetrance and this resistance, you can say that in general lines, the chance of a person that have one of these genes develop Alzheimer's disease is almost 100% in the genetical form of Alzheimer's disease, this rare Alzheimer's disease, not in most of the case of Alzheimer's disease, sporadic Alzheimer's disease that I think you'll be able to explain later.
Okay, great. Thank you very much. It's very interesting. Anybody else, would you like to add to that?
Yeah, I would love to add to that and maybe build on a question for Tariq. But I think that you're right. This is really getting a lot of headlines in the news, and we too have a lot of people who come to clinic to ask about this because I think we're all nervous about this, right? And we're all busy adults, so we do forget things every day, have word finding issues every day, just because we're busy and our brains are preoccupied. But it's scary because ultimately we worry: is this a symptom? But I just want to clarify, right, that this is different than those genes that folks are seeing in the 23andMe reports or other direct-to-consumer genetic testing reports. These are not highly penetrant genes that they're getting told back. So it's creating some concern and fear amongst patients that maybe is being overinflated in terms of its contribution to the development of the disease. And in particular, you know, when I talked about earlier, the combination of genetic predisposition, what we inherit versus our environment, in these types of genes where we're getting reports back from direct to consumer, environment probably is the larger contributor than that genetic predisposition. So I just wanted to ask Tariq to explain one more time those 3 genes that we know have high early onset Alzheimer's likelihood of developing as someone inherits versus the things that we see on these types of reports.
This is a very good point, and you heard about these questions every week in our clinics, and it's very important to communicate to the public. We have this genetic form of Alzheimer's disease, that this rare form of Alzheimer's disease, that you have these 3 genes that will determine that you have Alzheimer's disease, but only in a vast minority of the cases. As I said, it's the disease starts before 65 years old. If there are some characteristics, and this is not the common. Now we're going to talk about the sporadic Alzheimer's disease, the common Alzheimer's disease. This Alzheimer's disease, as Melinda just said very well, is influenced by causes that are genetic, but are also environmental causes, such as the life that you live, the diet that you have, many things that you cannot even quantify at this point. Then a genetical part is one component. Out of the genetical part, there is one polymorphism that's called ApoE4 genotype. That's the most important. Then what this polymorphism does, if I have this polymorphism that's called ApoE4, that's the one that you receive from the 23andMe, for example, if you have this polymorphism, your chance of have Alzheimer's disease compared with a person that don't have the polymorphism is 2-3 times more. Therefore, these are not diagnostic tests for AD. These are risk factors for Alzheimer's disease. Therefore, if you are a person that you did this test, you received this polymorphism, if you don't have any symptoms, you do not need to look for a doctor. What you should do, since you have a risk factor for Alzheimer's disease, a genetic one, you should act in the other risk factors of Alzheimer's disease that are the environmental ones. For example, you should have a better diet, you should do exercise to compensate the genetic risk factor. Then if you have status symptoms, if you appear with symptoms, another story, you should look for a doctor. But without symptoms, no. It's a risk factor and not a diagnostic test.
Okay, thank you very much. We did just have a question pop up in the Q&A. What is it in the environment that increases Alzheimer's risk?
Yeah, I'll try and have a go. So yeah, there's that it's difficult to quantify these things because in terms of the risk, I know when we also to come back to the earlier question, when we say Alzheimer risk or even the genetic forms in terms of all these mutations, what we do have that's happened is that there are about up to 10% of cases where you have people with these polymorphisms. So what it means is that there's a small percentage of people who likely have these family risk factors, risk genes that likely predispose them to the disease. So when you do all these genetic tests and then you see the polymorphism, there are very few people who have it. And oftentimes it comes from family line. Oftentimes maybe they had their grandfather or their mother or their father had it and then it gets passed along. So maybe most of us might not have to worry too much because there's a smaller percentage of us. For example, if we take like the 6 of us on this on the expert panel, statistically, if we take about, it's going to be 10%, then if you take out of 100 or out of 10 people, then there's a likelihood of one of us having it is much lower, right? Now, having said that, it means that the other 90% or about 90% of cases of Alzheimer's are from sporadic or idiopathic causes that we don't really can put a finger on it to say, okay, this is the cause. And that is when the environment comes in. There are multiple different things that have been linked to potentially being risk factors for Alzheimer's. Now, does it mean that if you do just one of those, it does remove the risk or it does increase your likelihood of not having? Maybe. But actually, if you go with a much more inclusive in terms of a healthy lifestyle, that's why it helps. So, for example, healthy living, all aspects in terms of improving your diet, the quality of the diet, the exercise. Of course, you don't have to go do things that are way outside your range, but do the things that you can afford to, right? If you start an exercise, do it smaller bits so that your body can get used to those. In terms of healthy living, in terms of healthy eating, and all those aspects. Now, some people do all of these aspects, everything that is in the books, but they still are not able to ward off the disease. Now, in that sense, what is it? Is it that, they're doing something wrong? Maybe there are also things that we do not know yet. There are some environments, and also there are also environment specific issues. There are some environments where you have, for example, pesticides. So those where areas where some pesticides are used a lot, that increases risk. There are also places where you have a lot of other toxicants, like the air in the area is not so good, maybe from some mining and all these aspects. So there are different risk issues. Even sometimes can come from car pollutants as well. So the things in the environment in a nutshell are quite broad. That increases one's risk to Alzheimer's, and not just Alzheimer's, also other types of dementias. Now, to be able to provide or to be able to get ourselves really, shielded away from it, there's a lot more that we all have to do, and we all have to do our bit to make sure that things get better for all of us.
Okay.
Oh, sorry, go ahead. I was just
No.
going to add that, yeah, I mean, I think this is the critical question, right? We all want to know what can we do to reduce our risk. And just like Thomas just reviewed, it's so challenging because we don't truly know what all those factors are yet or how they come into play together. And I think, that is one of the aspects that the All of Us study in particular is trying to address, not just with Alzheimer's, but all health conditions, is truly trying to understand what are those environmental exposures, what are the social and structural determinants of health that different individuals are experiencing each and every day in their lives, and how is that contributing to their ultimate health. Katie actually pulled up for me and showed me that there's over 110 current active studies around Alzheimer's specifically in All of Us already happening across the country. And many of these are specifically to try to better understand what are the exposures, what are the environmental factors and influencers that are impacting that development. And it's kind of cool because one of the unique things about All of Us is it's actually there are not a lot of individuals with a current diagnosis already in the database. And that has to do with consenting to participate in research, right? Folks who already have dementia, it is more difficult to consent to participate in research. But the cool thing is we'll be able to track this data over the next 20, 30, 40 years and actually see healthy people develop dementia or Alzheimer's type symptoms, and really then be able to understand what were all of their contextual exposures, so that hopefully for future generations, we can better answer this exact question when it's asked and really be able to pinpoint. But I really like what Thomas said is, even if any of us did every single thing in the book right now that we already know we could do to optimize our health, it is no guarantee that we will succeed and avoid development of the condition. But I think that's ultimately what we all want to be empowered to do.
And then I would like to add one quick point also, that with all these genetic mutations that we've heard about, that when one has, they really increase the risk. It's also more and more, that's what we knew, but later data continue to tell us along the line that actually it's not even absolute. So for example, there's some studies in recent times that have been showing that individuals who have, for example, ApoE, the ApoE4 gene, the allele, that we know is a really massive risk factor genetically for Alzheimer's. Now, it appears that In some individuals, in some populations, that is a massive thing, but in some other populations, it appears not to have such a big effect. And for a long time, what we knew was that ApoE, when someone has ApoE4 allele, they have a really high percentage of developing Alzheimer's. Now, that's why the value of research, that's why Alzheimer's Association, all these other partners are really helpful, because we continue to learn that by expanding the pool of populations that we study, we're beginning to understand that this is not or might not be absolute. So, for example, there's a recent study from a Brazilian brain bank where they looked at hundreds of people who had died. And in Brazil, the diversity in terms of race is really high there. So, and now there were individuals that had high European ancestry. What we know at the textbook knowledge really existed. Those that ApoE4 had high risk. But those who had high African ancestry, for example, had really low risk. Even if they had that ApoE4 allele, it did not really impact their likelihood of developing Alzheimer's really highly. And this opens up. So what are the different places that we have to look? All the different populations in the world, we have to expand. And again, also tells us one thing, that what the gene does, or the gene effect, might have some environmental connections that we really cannot understand fully at this time. And that also tells us that we need to be able to expand how much research we do day in, day out.
Right. Very interesting. Thank you. All right, our next question, can one of you shed some light on the difference between Alzheimer's disease and other dementia? And then also, what are the stages of Alzheimer's disease?
I can do. I think then you need to first differentiate what's Alzheimer's disease and what's dementia, because this is a very common and maybe the most common doubt that the patients have in the clinic. And then you need to understand that, let's imagine a patient, the patient have memory problems, have language problems, have difficulties to judgment. And when this starts to affect the capacity of patients perform the normal activities of the daily living, we call this dementia. Therefore, dementia are the symptoms. The dementia can be caused by 100 different pathologies. One of them, the most prevalent of them, is Alzheimer's disease. Then the difference of Alzheimer's disease for other dementia is the pathological substrate. For example, Alzheimer's disease is characterized by the deposition of two proteins, amyloid protein and tau tangle protein. Other dementias, we have, like I said, we have hundreds, but other dementias such as FTD can be caused, for example, for another protein called DDP43. Another cause of dementia is vascular. Vascular can be caused by strokes or small vessel disease. Therefore, and I think I can do a link here, I can expand a little bit, I can do a link for the biomarkers. Therefore, when a patient goes to the office, what the physician is seeing is the dementia. He sees the symptoms. Because there are a lot of experience and there are a lot of literature on that, each form of dementia has some clinical characteristics. For example, Alzheimer's disease starts with memory. Frontotemporal dementia of TD43 starts with difficulty of comprehension of the speech, language. Vascular dementia is something that different from the neurodegenerative dementias that progress slowly, progress in steps. The patient gets worse, stable, worse, stable. And this is due to the fact that the patients have actually strokes. When the patient have a stroke, he gets worse, then he gets stable until he has the other stroke. Therefore, when you go to a clinic, to a physician, he's going to see these characteristics, he's going to see the dementia only, and based on this characteristic, he's going to stipulate, probably this patient here have Alzheimer's disease because it starts with the memory. However, the physician and the best physicians will be wrong 20 or 30% of the time, because nothing avoid that, for example, the vascular are going to have a vascular stroke in the region of the memory. And for this reason, the physician see the syndrome, the physician see the dementia, and only with the biomarkers that the physician going to see the cause. And one of these causes is Alzheimer's disease, and have other 100 that are different from Alzheimer's disease in multiple different ways.
I'm really curious, Tariq, if you can explain the one level deeper about that, because as a primary care doctor, when folks come to me with symptoms, that is exactly right? I can diagnose consistent with dementia, and I might have a hint about the type, but I don't actually have the ability currently in my clinic to diagnose a subtype or a cause, pathophysiological cause of the dementia. And but we all on the call know that that's important to be able to do. And I was wondering if you could explain why that's going to be important in the next decade, so that we can not only make the diagnosis, but know which pathophysiological cause is happening regarding especially intervention and treatment.
Yeah, and we need to see a little bit of the historical of the disease, that until some months ago, we didn't have any FDA approval medication to change the course of the disease, or for that to be very effective for any other dementia that confound with Alzheimer's disease. Then using this more or less as a background, the people accept over the past many years and many decades that we are able to do the diagnosis clinically, and that you'll be wrong 20% of the times, under the assumption that doesn't matter if I do the diagnosis of dementia, exactly the cause of dementia, the treatment will be more or less the same. This will not going to impact the patient very much. However, the things change right now. We have medications to treat amyloid pathology. Soon we're going to have medications to treat tau pathology. Soon we're going to have medications to treat the diverse forms of dementia. Therefore, now you'll be able to identify the dementia. You're going to have a hint, I think it's Alzheimer, but you'll be able to confirm that is key to select the individuals to possible treatments.
Okay, sounds good. Thank you very much, Dr. Pascal. This question is for Clay. Does the Alzheimer's Association have information available on treatments and research or trial opportunities?
Yeah, so I think it's an exciting question to be able to answer at this point, because as Dr. Pascal just mentioned, with FDA-approved treatments and with what we see as a robust pipeline coming down the road, there are resources on how do you have those conversations, how do you navigate treatment options, and what does it mean? And ultimately at the association, that is our focus. Rather than the treatments, it's about access, so that if they approved, physicians can have those discussions with families. And so we could certainly drop in the chat some of those specific resources, but it is ongoing and updated to here's what we know, here's what we see, here's the questions to have with your primary care physician if you're interested, and here are all the factors that go along with it. I think to the participation in research trials component, it is a really interesting one, right? So the association has a service called Trial Match, where pulling from clinicaltrials.gov or other IRB approved trials, you can provide some information, find what connects with you, and even opt into, if nothing is of interest to you today, to get updates if something gets added that is. And I think that, certainly is an invaluable resource. But I would also say at the same, and there might be feedback from other panelists, living, depending where you live, you have access to really what is worldwide leading research in parts of Pennsylvania. And so how we may connect locally, hopefully we capture all of those things. And some of Trial Match could be remote, some can be in person. But the exciting part is with federal funding increases, with the association's funding, with private investors, we've seen research grow so exponentially. So certainly all of us, I'm sure, would have some input on how you connect with trials. And then from other perspectives, there may be other services or ways that are relevant to the folks on this call. So I would turn it over to the other panelists.
Yeah, I would like to talk, since you are talking about research and make some advertisement, and in line with what you said, the accessibility. It was launched exactly today, coincidentally or not, a study called CLIPAD. And in this study, we are making available blood biomarkers for Alzheimer's disease for all UPMC clinicians. Only need to have a UPMC email and a password. And this will work if any clinician that receive a patient, the patient have more than 55 years of age, the patient have an objective cognitive decline, and the patient has suspected Alzheimer's disease, because the tests are not to dementia, are for Alzheimer's disease. You need to have suspect Alzheimer's disease to be able to rule out Alzheimer's disease. Any clinician is going to be able to put the data of the patient. The patient will be contacted, and we're going to collect blood in the Montefiore's University of Pittsburgh CTRC. We're going to collect blood. In 10 days, the blood will be collected, and in more 10 days, the physician going to receive the results of the blood test. And this will be done with a rule-out threshold, meaning that this test to be able to rule out Alzheimer's disease in some cases. And this will be for free. And as part of a research funded, partially funded by the NIH. And this is available now. Any clinician that wants to do this can do this. And blood biomarkers are and Tommy can complement on that, are a very good way to give access to the people that are far from cyclotrons, are far from neurology that can do LPs. And I think this is the future.
Okay, great. Thank you very much. Next question. What is the difference between oral medications, Aricept, et cetera, versus Exelon patch? How do you determine which prescription is best?
I can do it. The oral medications in this case, they work well, but after some, it's not to work best or not, but after some dose of the medication, if you want to increase the dose of the medication after some dose, the patient accept better the medication that they have the patch. Therefore, you can imagine that the effect in the patient would be more or less the same. Just depend of sometimes the patient is easier also receive Exelon PET. Then there is no better or worse. If your doctor is prescribing one of them, this would be the more suitable for you.
Okay, great, thank you. And as we're talking about medications and that sort of thing, can anyone share what are the current treatments that are available for Alzheimer's disease right now, and how do they work?
Well, I guess that's one of the hot topics of the area now, which is really exciting. And for all of us, even when we entered the field, it was really quite gloomy because all one trial after the other, each of those fails. But now, suddenly, and I often try to equate it to what we saw with the COVID pandemic, where for quite some time, the pandemic hit us, and there was no way to really get vaccine or anything. And within a short period, there were multiple ones to choose from. And I think it's similar to what the Alzheimer field is seeing now, that with recently approved medications, of course, the previous ones were all treating the symptoms, but these current ones are supposed to target some of the pathological aspects. And the key ones, those that are on the market now, are those that target the amyloid. Now, as the amyloid is supposed to be one of the key pathological aspects that starts in the brain, and then it forms, built into clusters and deposits in part of the brain, and that is one of the main ways that at autopsy Alzheimer is confirmed. And we also believe that's one of the aspects that affect all the downstream, so the subsequent effects that we see in individuals who develop the disease. The current dose, so there are three. There's one that like the Leqembi. There's a new one, donanemab, that's been approved. Aducanumab was initially approved before all of these. It didn't have too much of a good press. But the whole thing is that these drugs target such a primary peptide, so a primary macro molecule in the brain that affect the disease, or that is key in the disease. And by targeting it, the trials that have been run, the individuals that were in the trial, what it showed was that those that were on the treatment had a reduction in the amyloid in their brain. And the exciting part was that one of these ways that these were measured were either they did PET imaging, where the individuals went through MRIs, but after having taken some chemicals that could penetrate into their brain, and they would bind to places where these amyloid deposits are. And then if you go through an MRI, then it will show color-wise, so we can see like a color coding, where there are good amount of those, the high color, those that are not have small colored dose. Now, what it showed was that these amounts reduced. So those who took the drugs had reduction. Those who did not take the drug, but were at the same clinical stages, did not see a reduction, which shows that there's a benefit. Cognitively, there was also some improvement in the memory, for example. So the symptoms that the people were seeing. One thing I also like to highlight there, that whilst they saw these effects with using more expensive aspect like PET imaging, even sometimes doing spinal taps, in the same individuals they took blood samples and then they run the blood test that we currently have developed for Alzheimer's. And the beautiful thing was that the same result they saw going through the more expensive and the more difficult approaches with looking directly into the brain, you could see the same thing using very simple blood samples that, just come here, let's take a blood sample, and they saw the same results, which gives a lot of hope that what we can do going forward is that we'll be able to use blood tests. These blood tests will be able to identify and to monitor as many people with the disease, and those who are to monitor those who are on the treatment, whether the treatment is going well, whether the treatment is going not as expected, or are the people recovering as we think they should with the pace that they should go compared with everyone else. And those are some of the aspects that we think will be really nice. And those are some of the things that we are doing really well in Pittsburgh here. And we're going to continue to partner with the Alzheimer Association, for example, to continue to expand these. And it's really exciting with the study that Tariq's group has started, because what it means is that we can start to get real world information on how these blood tests perform, because we've used historical samples before these trials. There are lots of cohorts where we use for these studies, but these are from historical samples that were limited to people who were willing and available to enroll in these trials. The problem is that you often would get selection bias, because there's only people who understand the value of research and are willing to go through all the procedures that would enroll. And that for that reason, I often say that we've made these diseases more like, as I call, like luxury disease, because it's those who can afford to join are the ones that we get the data on. There are a lot of people in the other part of the cities, in the other part of the world, in that they don't have the time and the value, or even the historical context to join this research based on the procedures that they have to go through. So by expanding to use methods that are more accessible to everyone, because not many people would oppose to taking a simple blood test or taking blood from them, that makes it way easier for everyone to join. The cost also would come down a lot compared to going through all those complicated procedures.
Gotcha. Okay. Thank you very much, Dr. Kari. Can we also talk about the importance of early detection and diagnosis? We have a question in the Q&A. When should you be concerned to see a doctor? What are some of the symptoms? So I think early detection and diagnosis, very important here.
Yeah, I think I can probably field that from the primary care side again, where I think often that's the first place a person would go if they have concern, is to their PCP. And then if the PCP also has concern, would refer to one of our specialist colleagues for further diagnostic evaluation. So I can tell you, I don't know that there's a clear set of criteria of when it's the right time to go see your doctor, but the types of things that I see that are often brought to my attention are things like Tariq said earlier, things that are interrupting your ability to do your daily living activities. So if you're really struggling, all of a sudden you've cooked meals for a family of 8 your entire life, and all of a sudden you're having a hard time organizing and completing a meal in a timely manner, and finding that really challenging or overwhelming. Or an example that I've even seen happen in real life, we have all this road construction in Pittsburgh, and you've driven a road home every single day, and now there's a rerouting of the road because of construction, and you can no longer remember how to get home, and find that challenging and frustrating and overwhelming. And I've actually seen this with someone who pulled over on my street, who was just distraught. And so these are the types of things that are true concerns. So it's really disrupting your ability to function on a day-to-day basis. I think a lot of us get nervous for things that are normal and common. And I want to reassure folks that we're managing, there are 100,000 balls in our head at any given moment that we're juggling around. And so occasionally dropping one, occasionally, forgetting a word or not being able to find the right word, occasionally putting your keys in the refrigerator, it happens to all of us. But I think those are the things that are really scary to patients. But truly the things that inhibit your ability to function on a day-to-day basis, right? For those who still balance a checkbook, finding that you're not succeeding at that anymore, or remembering how to do that, navigating, obstacles and coordinating complex things that require a lot of ability to put thoughts together are the things that come to mind. I don't know if my colleagues would like to add to that.
Yeah, I think one thing that I always try to talk for the patient is that the patient needs to compare him with himself some years ago, some months ago. It doesn't work compare with other individuals and talk generically. Oh, if you forget where you put the key 3 times in a month, this will be something. No, have people that forget from the teenager 3 times a month where to put the key. Then what the patient should be concerned is with a change that he's seeing, and if his change is important and is concerning himself or someone around him.
And I would just add to that, because I think that someone around them is that is often what we see, right? This is a disease that has stigma, but impacts families and communities. And so it is often a loved one or a coworker or a social contact who notices some of these things. And so I think that's one of the things that encourages to have a conversation, right? Whether you're concerned about yourself or you see it in someone else, whether it's something that we could treat effectively or at least work to find the underlying cause, time is important. And so often we see families and individuals who wait 2, 3, 4, 5 years until something really acute happens. And then it's a much different conversation and a much tougher conversation, and often not with the primary care physician who you've come to know and trust around all your other medical issues. It may be in an emergency room or some other situation. And so we'll just encourage that side of it for all those listening.
Okay, great. Thank you all. Next question. An attendee heard that staying up to date with her flu and pneumonia vaccines could reduce her risk of Alzheimer's disease. Any truth behind this?
I can answer. Well, this data, this type of data, they come from epidemiological studies, where the people take a huge database from the government normally, and they correlate vaccines with the development of Alzheimer's disease. The good thing of these studies are the large number of people. The bad thing of these studies is that you are looking at the database, are not looking at the individual. Then epidemiological studies are super important, but they are more important to raise questions that normally should be answered by a clinical trial and a study that you're going to see the patient, not the database. In saying that, I don't know any clinical trial that tests that. Then I would say that it's possible that these vaccines, for some reason, decrease the risk of develop Alzheimer's disease for some mechanisms such as immunity that is key for Alzheimer's disease. But this is also possible that that you call confounding factors. For example, a person that take vaccines probably take better care of many other areas of the life. Maybe is one of these other factors that are associated with Alzheimer's disease. Therefore, as today, we cannot answer if it reduces the chance of Alzheimer, but this is very different of a patient go to your office, a patient with MCI, Alzheimer, and ask if she should do the flu vaccine or any vaccine. And this is different because we know that if a patient with Alzheimer's disease get infected, he's going to take more time to do the diagnostic. He's more likely going to go to the hospital, more likely going to stay more time in the hospital. He's more likely going to have a serious complication in the hospital. Therefore, I will not say for a patient that he should take the vaccine to reduce the risk of develop Alzheimer, but I would say for a patient that it's good to take the vaccine to take care of the general health and have less risks, even more if for a patient that have a neurodegenerative disease, because the prognostic of these infections is worse in who has neurodegenerative disease.
Okay, great information. Thank you, Dr. Pascal. An attendee would also like to know, staying on this topic of vaccines, if you think that a vaccine for Alzheimer's disease could come to fruition and if Pitt is conducting any research on it.
Well, as Tommy explained, we have these new medications like anumabi, aducanumab, donanemab, and these medications are immunotherapies. We call passive immunotherapies. We give the antibody for the patient, and the antibody go there and binds, for example, to amyloid plaque, and binds and avoid that amyloid aggregate or help to the diffusion of the plaque. The vaccines are the same logic, but they are active immunity. Instead, prepare the antibody outside the patient and give the antibody to the patient. You inject a substance in the patient going to produce this antibody, and this antibody going to remove the amyloid in the brain. We have early studies that were not very successful. Some studies did not remove, we have more anti-amyloid therapies. Some studies did not remove the amyloid plaques, and the other study removed, but you have a very serious side effect. And then these studies stop. There are some studies in phase 1. I don't know if I have phase 2. My answer is, since this technique already show the potential to remove amyloid plaque, I will not get surprised if you have a vaccine for Alzheimer's disease, that the researchers find the sweet spot between the effectivity and the side effects, and maybe it's something to the future. I'm not going to exclude this possibility. I don't know of any study in Pittsburgh. I don't know if Tommy knows, or I don't know. No,
and in the same way, there are people who've been chasing this angle, both with the immunotherapy, with that Tarek explained really well, and then with the vaccines. There's some vaccine approaches or other forms of gene therapy also that are being pursued. The one aspect is that we've seen these immunotherapies that have been successful today, but we also expect is that it's going to be open the floodgate for multiple other treatments to come into the market. Maybe in 3-5 years to come, there might be about 10 treatments to think about. Instead of just the immunotherapies, there might be multiple other ones that go on the market. In a way, maybe that also will be a way to help us to move closer to what people have been touting as precision medicine. That maybe some treatments might be good for individuals with a certain phenotype or with a certain clinical presentation, while others might be better for other individuals. Maybe I'll try to link it somewhat to the COVID vaccine. That since we got several those from several companies, then I got to a point that for individuals who might be having some reaction to some vaccine, they're like, okay, maybe take the other one, but that might be better for you. This might be where we'll get to once we get multiple disease treatments on the market.
Great, very interesting.
I would add, I think there's one thing that comes out to the questions to me, and particularly the vaccine questions. One of the commonalities is these are all things that have been covered in the media within the past couple of weeks, right? There was articles around the nasal vaccine, and then company Vaccinity, who had moved through phase 2 trials. There may be other thoughts, but I do think that is one of the things we do have a venue today to ask questions, but if we have questions on anything we see on the news or others, right? Place like the association, you can contact our 24/7 helpline to get answers. You can contact your local physician as they may be able to look into it. Others on this call may have recommendations, but part of the excitement of entering this era of treatment and all of these research advancements moving, sometimes it's difficult to suss out what is what. You have experts today, but if a month from now or 2 months from now, knowing that you could still reach out to places to get better information, to get clarity for your questions, I think that is incredibly important because we are just in the midst of a rapidly changing landscape around all of this work.
Thank you for that. Okay, let's see. We have time for maybe a few more questions. Here's something else that's been in the headlines recently. We were asked if you have heard of the new headband for detecting Alzheimer's disease, and do you think it will work?
I can answer if you.
Yeah, you go.
You want to go? Well, headband you said? Headband?
Headband, yes.
Okay. These things are in fact adaptations of electroencephalogram. Electroencephalogram we have in neurology, I don't know exactly, 50, 100 years. And you have many studies, and you have many studies with Alzheimer's disease when the results of the electroencephalogram, when the patient are awake or when the patient is sleeping. What this electroencephalogram can give in terms of information, I think probably this group, what they did was create a hardware that they adapt and the patient can use easily in their home, probably when the patient is sleeping. What this test can offer to us? Normally, this test can offer to us is they observe the pattern or the abnormalities related to the sleep of the patient, because we know for many years that the electroencephalogram you can see the quality of sleep of a person, if you will. We know as well that sleep is highly associated with memory, and sleep and memory are associated with Alzheimer's disease. Therefore, if you take what you discussed before, that the clinician see the symptoms and the biomarker give the pathology, in terms of diagnostic, as I understood your question, this will not going to help the clinician at this point very much, because what you are saying that are abnormalities that are associated with memory problems, something that the clinician already see in the clinical practice. At this point, probably, and I already find that this correlates with amyloid and tau pathology, but this is not very accurate for define the pathology of AD with the data that you have today. I will not, once again, I will not get surprised if now with this big data and AI, we cannot discover a pattern that's a pattern that are related to memory decline, not with amyloid pathology or tau pathology. I'm not going to get surprised if you can discover some slightly things that a human being cannot see, but maybe the AI can see try to identify what's the memory problem associated with the position of amyloid tau or other. But I don't think, then my answer is, I don't think that you are there in terms of diagnostic. However, I think this can be very good for research, for monitor brain health in people home, people that don't have Alzheimer's disease, to try to find the very early abnormalities in memory that maybe you cannot see in the cognitive tests. And maybe the future, if you have a lot of data with AI, maybe this can bring us close to identify also, besides the problem in memory, the position of proteins, if you will.
Great. Thank you very much. Does anybody else have anything they would like to add before we wrap up here? Anything you would like our participants to know?
I think probably the last question and the answer from Tarek actually tells, it links back to the title of the session, Hope Beyond the Headlines. Because, and I know it's really, sometimes it's confusing, it's a lot, because the consumption is a lot. There are a lot of different messages that come in the press, and then you don't get the full picture behind it. And it's like, oh, we found a new treatment for Alzheimer's. So we found a new signature for Alzheimer's. If you have X, it means you're going to have Alzheimer's, or you're going to die in the next 10 years. Sometimes it brings a lot of panic. But with having sessions like this, we're able to, to digest, and also to, without any conflict of interest, because it's not like none of us is paid by a company to do their bidding or not, that we're able to do it this way. And one good thing is that we also have the Alzheimer's Association and the all of us PA, that for future use, people could refer to, that if we are aspects in on the headlines that you really don't understand well, that you can approach them and the experts can provide all the explanations to you.
Exactly. Well,
I'd just like to thank you guys. Thank you, Brittany, Clay, for the invitation, and say that this kind of thing, linking us with the people that use our research in the end, is very important to us as well, because make us think in a different way, and this can enrich our research. You can be reminded that our goal is translating something simple for the patient. And it's an honor to share here with Tommy and with Melinda representing all of us. That's an asset to Pittsburgh, but also to the whole country. Thank you very much. It's an honor to be here.
Thank you very much to our panel, to everyone who attended today. This was really great information, and thank you for sharing it with us. Once again, if you registered, you will receive a follow-up email with links to resources from the Alzheimer's Association, including Trial Match, what Clay talked about, how you can participate in a clinical trial. It will have our 24/7 helpline number on there. If you ever have any questions or need support, We will also have a link in that email on how you can participate in the All of Us research program. Again, this webinar is being recorded and will be available on our YouTube and social media channels as well for All of Us and the Alzheimer's Association Greater Pennsylvania chapter. So thank you, everyone, and have a great rest of your day.
Thank you.